Acute kidney injury is common, dangerous, and often preventable when detected early. This session explores how novel biomarkers are revolutionizing acute kidney injury diagnosis and management beyond the traditional biomarkers. Hello everyone, I am Dr. Maitri Shankar, Associate Professor in Nephrology at Institute of Nephrology, Bengaluru, India. The key learning objectives are to understand the impact of acute kidney injury and why conventional markers like serum creatinine and urine output fall short in early detection and also in risk stratification. To explore the functional markers, tubular injury indicators, and cellular stress biomarkers with distinct clinical roles, to evaluate sensitivity, specificity, and prognostic value across various clinical settings like ICU, perioperative setting, and in the setting of sepsis where AKI is very common. Practical integration such as when to send the sample, how to sample, what are the cost considerations, and what do the guidelines recommend to add to the clinical pathways? Some future directions to recognize the challenges in standardization and emerging technologies like proteomics and metabolomics in acute kidney injury. To interpret biomarkers with clinical reasoning within the patient context for enhanced diagnosis, risk stratification, and personalized care. Acute kidney injury occurs in 1/4 of all hospitalized patients, with even higher rates in the setting of ICU. Acute kidney injury independently increases in-hospital mortality by several fold across all patient populations. Unfortunately, creatinine rises only after substantial GFR decline, missing the critical early intervention window. Even mild acute kidney injury meeting KDIGO stage 1 criteria significantly increases short and long-term mortality, hospital length of stay, and healthcare costs. AKI episodes create lasting consequences, serving as strong risk factors for subsequent chronic kidney disease, progression to end-stage kidney disease, and cardiovascular events, even when the creatinine appears to recover. Why AKI matters across medicine. AKI complicates management of virtually all serious illnesses, including sepsis, cardiothoracic surgery, heart failure, and other major surgeries. AKI limits therapeutic options and necessitates careful drug dosing adjustments and meticulous fluid and electrolyte management. Beyond immediate mortality risk, AKI creates a cascade of complications affecting kidney function, as I already mentioned, such as progression to CKD and end-stage kidney disease and cardiovascular events, and overall prognosis for over years. What is the problem with creatinine? Creatinine rises only after substantial GFR decline and distribution equilibration is reached, which is typically 24 to 48 hours post-injury. Early, potentially reversible damage goes undetected because of this. There are multiple confounders such as muscle mass, metabolic state, liver disease, volume status, and drugs affecting tubular secretion. All of these alter creatinine levels independent of the kidney injury. Small absolute creatinine changes can represent large GFR drops in patients with normal baseline function. So normal creatinine can coexist with significant impairment in the kidney function. So the relationship between serum creatinine and GFR is definitely nonlinear. Poor phenotyping. Creatinine cannot distinguish hemodynamic prerenal azotemia from intrinsic tubular injury, nor it can detect subclinical ongoing damage in patients with stable creatinine values. So creatinine will be increased in cases of prerenal azotemia and also in ATN. We cannot differentiate between the two. Coming to limitations of urine output, it is a non-specific signal because oliguria may also reflect hypovolemia, low cardiac output, obstruction, or neurohormonal responses rather than structural kidney damage alone. Some patients with clear tubular injury may still remain non-oliguric. There are effects of certain interventions like use of diuretics, fluid resuscitation, vasopressors, and osmotic agents, all of these can alter urine output without changing the underlying kidney injury. So this will make the interpretation of urine output challenging. Accurate hourly urine output will require catheterization and meticulous charting. So this can be achieved in ICU settings. Outside of ICU, it is very difficult to accurately measure hourly urine output. So coming to the case for novel biomarkers. Traditional markers fail in various areas. They detect acute kidney injury relatively late. They provide limited pathogenetic mechanisms information. They're easily confounded by non-renal factors. They cannot distinguish the cause or types of acute kidney injury, and they miss subclinical damage. Serum creatinine may be normal, but there might be ongoing subclinical damage. What do novel biomarkers have to offer? They are elevated 2 to 4 hours post-injury, so helps in early detection. There are specific tubular damage markers, so you know that if these markers are elevated, it means that the tubules specifically are damaged. There are cellular stress indicators. There is improved risk stratification with the help of these biomarkers. They also provide pathomechanistic insights and prognostic information. So broadly, there are three categories of AKI biomarkers. Functional markers, these indicate changes in glomerular filtration reflecting impaired overall function, but may not distinguish mechanisms of injury or rise early. Second are damage markers. These are released from damaged tubular epithelial cells reflecting structural injury independent of current filtration or urine output. Third are stress markers. They detect cellular stress responses before the cell death or overall functional decline, providing earliest warning of impending injury. Clinical use of panels combining markers from different categories optimizes diagnostic accuracy and risk stratification beyond what any single marker can achieve. So here is the proper classification of biomarkers in acute kidney injury. Functional markers, mainly serum creatinine, cystatin C, pro and cephalin A. Stress markers, DICOV-3, TIM2, IGF-B7. Damage markers, predominantly CCL14, interleukin-18, NGAL, interleukin-9, liver type fatty acid binding protein, KIM1, N-acetylglucosamine, and so on. Functional markers tell us about the overall kidney performance but provides limited information about the underlying cause, location or severity of structural damage. They represent the what of kidney dysfunction but not why or how. Two important functional markers are serum creatinine and cystatin C. Serum creatinine is most widely used marker. However, it is late and insensitive to early injury, but still remains essential for AKI staging and monitoring. Cystatin C is low molecular weight protein filtered by the glomerulus. It does not undergo any tubular secretion. It rises with early GFR decline and is less affected by muscle mass or dietary factors than creatinine. Damage markers, they are signals of tubular injury. The important ones are NGAL, KIM1, interleukin-18 and liver type fatty acid binding protein. NGAL is neutrophil gelatinase associated lipocalin which rises within 2 to 4 hours after injury from ischemia or toxins. It is detectable both in the urine and plasma. KIM1 is kidney injury molecule 1. It is highly specific to proximal tubular injury. and elevated within hours after toxic or ischemic insult. Interleukin-18 marks inflammation and tubular cell response, rising early during tubular injury with particular utility in sepsis and in pediatric population. Liver type fatty acid binding protein is a urinary marker for proximal tubular injury, especially effective in the context of ischemia. Stress markers are the earliest warning signs. They detect cellular responses to injury even before structural damage becomes irreversible. So this gives us a critical window for intervention if there is any. The urine rise indicates risk of acute kidney injury development in the next 12 to 24 hours. So we have TIM2, that is tissue inhibitor of metalloproteinase 2, which induces G1 cell cycle arrest in stressed tubular cells rising before cell death occurs. Insulin-like growth factor binding protein 7 also triggers cell cycle arrest. Together with TIM2, it forms the FDA-approved NephroCheck panel. DICOF3, it is an emerging marker reflecting tubular stress and susceptibility to injury. However, this is still under investigation and not widely available clinically. So this is basically the summary of biomarkers, the categories of biomarkers. Functional biomarker examples are creatinine and cystatin C used for diagnosis and staging, limited early sensitivity. Damage biomarkers like NGAL, KIM1, interleukin 18, and liver type fatty acid binding protein helps in early detection, mechanism identification, and gives prognosis. Stress or cell cycle arrest like TIM2, insulin-like growth factor binding protein 7, and DICOF3 helps in risk prediction, and it is the earliest warning signal available. So let's look at some evidence in clinical settings such as cardiac surgery. The performance of NGAL in cardiac surgery has been studied. Both urine and plasma NGAL rise as early as 2 hours after cardiopulmonary bypass. Meta-analysis shows AUC of 0.75 to 0.86 with 86% sensitivity and 80% specificity. KIM1 is also studied and has good AOC and sensitivity and specificity of around 85%. TIM2, insulin-like growth factor binding protein 7, they have a pooled AOC of 0.82 to 85 for predicting moderate to severe AKI and requirement of renal replacement therapy. It is FDA approved for prediction of KDIGO stage 2 to 3 AKI within 12 hours. Cystatin C timing, it rises within 12 to 24 hours post bypass with best AUC approximately 0.81 at 12 hours, which is much earlier than the elevation in creatinine. So in the setting of ICU and critical illness, NGAL is useful for early detection with good sensitivity and specificity. However, specificity may be reduced by sepsis and systemic inflammation because neutrophil gelatinase associated lipocalin can be elevated whenever there is neutrophilic leukocytosis because of sepsis, so it can show false high levels. TIM2 and insulin-like growth factor binding protein 7 have been studied in ICU and critical illness settings for AKI and RRT prediction in heterogeneous ICU populations. They also predict 28-day mortality. Interleukin 18 also performs well in ICU and pediatric sepsis studies. KIM1 has been shown to be elevated in sepsis-associated AKI with AOC of 0.6 to 0.8 depending on the population and timing. It is also associated with the requirement of kidney replacement therapy and 30-day mortality. So for sepsis-associated AKI, NGAL has a sensitivity of 76%, interleukin 18 has a sensitivity of 92.5%, and the AOC is 0.88. KIM1 levels independently predict sepsis severity and requirement of RRT and also multi-organ dysfunction. So here is a table showing the performance metrics across various settings. NGAL and KIM1 have been studied very well in cardiac surgery settings. NGAL is the earliest to rise within 2 to 6 hours. KIM1 is specific for proximal tubular injury. TIM2 and IGF-BP7 are studied in post-cardiac surgery settings and also in critical illness and ICU care. Both of these are FDA approved, called as nephrocheck. Interleukin 18 works well in sepsis and ICU settings, especially in pediatric sepsis population. Coming to the prognostic value of biomarkers, correlation with severity, NGAL, KIM1 and interleukin 18 levels correlate directly with the severity of AKI, need for renal replacement therapy and mortality in ICU and sepsis population. TIM2 IGF-BP7 predicts requirement of kidney replacement therapy, 30-day mortality and 28-day mortality in cardiac surgery and ICU population with good discrimination. Cystatin C is a strong predictor of mortality, progression of acute kidney injury, and adverse outcomes in perioperative settings. So some key evidence insights: context-specific performance. NGAL, KIM1, TIM2, IGF-BP7 and cystatin C have the strongest evidence for early detection and risk stratification, especially in cardiac surgery and ICU. Interleukin 18 performs exceptionally well in sepsis and pediatric settings but shows moderate sensitivity in general ICU population. There is wide variability of cutoff. All biomarkers require context-specific cutoffs and should be interpreted alongside clinical variables rather than having universal thresholds. Combining markers from different categories like functional, damage, and stress categories consistently outperforms just utilizing single biomarker approach for both diagnosis and prognosis. Practical considerations. So here is the timeline of rise in biomarkers. 2 to 4 hours, the earliest to rise are the stress markers, NGAL, TIM2, IGF-BP7. They rise within 2 to 4 hours after injury, providing the narrowest window of opportunity for intervention. Between 6 to 12 hours, damage markers are the ones to rise. These are KIM1 and interleukin 18, which are markers of tubular injury, indicating established structural damage requiring different management lines. 12 to 24 hours, functional markers begin to raise. Cystatin C rises after 12 hours, between 12 to 24 hours, earlier than creatinine but later than the damage markers. 24 to 48 hours is the time when creatinine starts to rise. Traditional creatinine elevation occurs last, often missing the critical window for early intervention. A single measurement may not capture the evolution of injury. Serial testing is often required for ongoing monitoring and to distinguish transient stress from progressive injury. The context definitely matters to interpret results within the clinical timeline. So which sample to use, urine sample or plasma sample? Urine biomarkers are NGAL, KIM1, interleukin 18, TIM2, IGF-BP7 and LFABP. They reflect local tubular injury directly. Urinary biomarkers are definitely non-invasive to collect, so that is plus point, but it is affected by hydration status, urine concentration, and may also need normalization for creatinine values. Urinary samples are usually unstable and require immediate processing. Plasma and serum biomarkers include NGAL, cystatin C, and proenkephalin. These are easier to standardize and less affected by urine output. They may have broader diagnostic performance in some settings. However, we should remember that plasma NGAL can be confounded by neutrophil activation in sepsis. In the perioperative settings, plasma markers may outperform urine markers. For TIM2 and IGF-BP7, these are the only urine biomarkers that are validated and approved by FDA. So choose the sample type based on the clinical context and the available infrastructure. Cost and accessibility. NephroCheck cost per test is approximately 12,500 INR. For other standard biomarkers, it is approximately 2,235. The device investment for NephroCheck or biomarker assessment is approximately 4.5 lakh INR. There are also some challenges associated with implementation. Biomarker results must reach the clinicians fast to help them in timely intervention. Electronic alerts and clinical decision support systems can help, but they require integration with IT and redesigning of workflow. Lack of universally accepted cutoff means that results must be interpreted alongside clinical history, baseline kidney function, and CKD status rather than using simple thresholds. Assay performance varies by the platform that is used, patient population, and also the clinical setting. Models trained at one site may not transfer well to others without local validation, so all of these devices and biomarkers require local validation. Even with early detection of AKI, there is a lack of proven therapeutic interventions. This limits cost benefit justification for routine biomarker use in many settings. So what do the guidelines recommend? KDIGO 2012 AKI guidelines suggests biomarkers may be used to identify patients at high risk for AKI, but acknowledges insufficient evidence for routine clinical use at the time of publication. KDIGO 2024 CKD update recommends a statin C-based EGFR for select patients when creatinine is unreliable, highlights evolving role of biomarkers in CKD staging and risk prediction. Acute Disease Quality Initiative Consensus 2020 recommends using panels combining stress, damage, and functional markers for the diagnosis of AKI and also for risk stratification. FDA has approved TIMP2 and insulin-like growth factor binding protein 7 biomarker combination, which is called as NephroCheck. This is the first FDA-approved urinary biomarker test for AKI. Risk prediction. It predicts moderate to severe AKI within 12 hours in ICU patients. Some clinical scenarios where these biomarkers are ready for implementation. These are in hepatorenal syndrome, where urine NGAL has been studied and validated to distinguish acute tubular necrosis from hepatorenal syndrome. Acute interstitial nephritis, the combination of three biomarkers TNF alpha, interleukin 9 and CXCL9 improves diagnosis, drug safety monitoring, and kidney transplantation. So we will look into these clinical scenarios in detail. Hepatorenal syndrome versus acute tubular necrosis. The performance of urine NGAL has been demonstrated in 1,200 patients with very good sensitivity, specificity, and AOC. The optimal cutoff is 220 micrograms of NGAL per gram of creatinine. And this helps us in decision making of whether to use terlipressin to actual HRS patients early in hospitalization. Coming to acute interstitial nephritis, diagnosis is established by combination of three biomarkers, that is TNF alpha, interleukin 9, and CXCL9. So these three biomarker combination has been validated. Kidney transplantation biomarkers, ratio of uromodulin divided by osteopontin. Ratio of less than or equal to 3 is associated with lower risk of delayed graft function, higher 6-month EGFR, and lower risk of graft failure. This can reduce more than 1,000 yearly kidney discards because of donor AKI. YKL40 concentrations, higher donor YKL40 is linked to reduced delayed graft function risk, higher 6-month EGFR, and 50% lower risk of graft failure. So there are point of care lateral flow devices which are undergoing development for real-time allocation decisions. FDA approved applications are in drug safety composite panel. FDA qualified biomarkers in this panel are cystatin C, clustrin, KIM1, N-acetyl glucosamine, neutrophil gelatinase associated lipocalin, and osteopontin. This is used in phase 1 to 2 clinical trials to detect nephrotoxicity induced by drugs. Combination of TIM2 and insulin-like growth factor binding protein 7. This is FDA approved for risk assessment of moderate to severe acute kidney injury within 12 hours in ICU. Urine NGAL in children. This was FDA approved in December 2023 for risk of persistent moderate to severe AKI within 2 to 3 days in critically ill children aged 3 months to 21 years. Clinical scenarios range from ready for implementation, as you can see on the left side of this table, to requiring more validation. This is on the right side of the table. AKI in cirrhosis, critically ill children, and drug safety monitoring have met key milestones, including establishing cutoffs, external validation, and potential to change management as well. So, the other areas where these biomarkers are under study are in kidney donors and in the setting of post-acute kidney injury, predicting which are the patients who are at risk of progression to chronic kidney disease. Coming to post-AKI care and monitoring, only a minority of patients with acute kidney injury receive prompt nephrologist follow-up. There are some promising biomarkers which predict patients with acute kidney injury who are at high risk of progression towards chronic kidney disease, end-stage kidney disease, and even cardiovascular outcomes. These biomarkers are plasma tumor necrosis factor receptor 1, 2, urinary MCP1, uromodulin, YKL40, and EGF. These biomarkers help to better identify high-risk patients who are at the risk of progression to chronic kidney disease and who are at the risk of poor cardiovascular outcomes as well. The NIH-funded COPE-AKI consortium will test interventions to reduce readmissions in stage 2 to 3 AKI survivors and validate these biomarkers for post-AKI care. So let's look at the emerging technology, which is the proteomics. Advances in mass spectrometry has enabled unbiased identification of novel proteins and protein panels associated with acute kidney injury across diverse populations. Discovery of the biomarkers that are already established like NGAL, KIM1, and interleukin 18 emerged from proteomic screening approaches, validating this technology's potential. Future proteomic profiling may identify AKI endotypes and subtypes, guiding precision medicine and enabling targeted therapy. The future lies in combining functional, damage, and stress biomarkers with clinical risk scores and emerging omics data into integrated panels that optimize prediction and also help us in guiding treatment modalities. Machine learning approaches may enhance predictive accuracy by integrating genomic, proteomic, and metabolomic signatures with the clinical history and the clinical data that is available. AI can identify complex patterns in multi-marker panels that human interpretation might miss. This will improve risk stratification as well. Efforts are underway to develop real-time bedside point-of-care devices that can utilize these multi-marker panels for rapid detection of acute kidney injury. So this was a study conducted by Kashani et al. In the year 2013, which clearly indicated that clinical history and clinical findings of the patient, clinical context of the patient definitely improved the accuracy in predicting acute kidney injury. NephroCheck alone had AOC of 0.66, but when NephroCheck was combined with clinical parameters such as age, history of chronic kidney disease and procalcitonin levels in the same population, the AOC increased to 0.75. So there was clearly 14% improvement in predictive accuracy by integrating clinical context along with the biomarkers. The proposed substaging integrates biomarker positivity with creatinine and urine output criteria, allowing earlier identification of patients with subclinical or evolving injury who may benefit from preventive strategies. Stage 1S, S stands for subclinical. In this stage, biomarker is positive without creatinine or urine output criteria met. This identifies patients with tubular stress or early injury. In this stage, serum creatinine levels are still normal, but there is ongoing subclinical injury. Stage 1A, mild. It meets KDIGO stage 1 criteria with negative biomarkers, likely functional or pre-renal without structural damage. Stage 1B is moderate, meets KDIGO stage 1 criteria with positive biomarkers. It indicates structural injury requiring close monitoring and intervention. Renal angina index. This is a validated model which combines demographic risk factors, clinical context, and early signs of injury like oliguria or fluid overload to identify patients at highest risk for acute kidney injury progression. This validated model helps clinicians prioritize which patients need biomarker testing and intensive monitoring. This will help us in optimizing whatever limited resources we have and also helps in improving early detection of acute kidney injury. So how do we enhance early diagnosis of acute kidney injury? Between 2 to 4 hours is the time for detection. Biomarkers detect kidney stress or injury hours before creatinine rises, providing critical intervention window. Between 4 to 12 hours is the stage of assessment. Combine biomarker results with clinical context to determine injury severity and the possible mechanism of injury. Between 12 to 24 hours is the time for intervention. Initiate supportive strategies such as fluid optimization, avoiding nephrotoxins, adjust the drug doses according to EGFR, and make sure the hemodynamics are stabilized. Between 24 to 48 hours is the time for monitoring. Monitor biomarkers serially. Serial biomarker measurements are very important to track the evolution of injury and also response to treatment. Risk stratification and prognostic enrichment. High risk patients are the ones who have positive biomarkers with critical clinical factors. Moderate risk are the ones with either positive biomarkers or critical clinical risk factors. Low risk are the ones with negative biomarkers and low clinical risk. A positive nephrocheck, that is a value of more than 0.3 nanograms per ml square divided by 1000, identifies patients at high risk for moderate to severe acute kidney injury. Adding clinical risk factors further improves discrimination and allows targeted intervention. Biomarker guided algorithms help identify which patients may benefit from intensive monitoring, early nephrology consultation, and those who require modified care bundles. Now, what do we mean by biomarker guided care bundles? So that includes hemodynamic optimization, that is goal directed fluid therapy and blood pressure management to maintain renal perfusion without volume overload. Reviewing the medications, discontinue ACE inhibitors, ARBs, NSAIDs and other nephrotoxic drugs and adjust dose according to GFR. Tight glycemic control to reduce metabolic stress and to minimize additional kidney injury. Minimize contrast exposure, avoid aminoglycosides, and carefully time necessary nephrotoxic therapies. So there was one study which looked at the biomarker guided care bundle. This study was the BIPAC trial, which was published by Smith et al. In the year 2020. The BIPAC trials implemented a KDIGO-based AKI care bundle in patients with positive biomarker results after major surgery. And the results showed that biomarker guided bundle implementation significantly reduced the incidence of AKI and severity compared to standardized care. So where is research required at present? We need studies to standardize. Multi-center efforts are required to establish universal assay methods, universal reference standards, and validated cutoffs across diverse populations. Therapeutic trials are required, biomarker-enriched clinical trials testing targeted intervention in high-risk patients to demonstrate outcome benefits. Multi-omics integration, that is combining proteomics, metabolomics, and genomics with the clinical data to create comprehensive diagnostic tools. Development of technology, creating rapid point-of-care devices that provide real-time results to guide immediate clinical decisions at the bedside. Studying optimal strategies for integrating biomarkers into clinical workforce and measuring the real-world impact, which is nothing but implementation science. Key messages for clinical practice. Early detection matters. Novel biomarkers detect AKI hours before creatinine rises, providing critical window for intervention that can prevent progression and also improve outcomes. Context is important. Biomarkers must be interpreted within clinical context, combining with risk factors, disease severity, and patient characteristics for optimal accuracy. Panels outperform singles. Multi-biomarker approaches combining functional damage and stress markers consistently outperform single markers for diagnosis and prognosis. Biomarker-guided care bundles have demonstrated ability to reduce the incidence of acute kidney injury and severity when implemented systematically. Use of biomarkers is in fact a new era in the management of acute kidney injury. Biomarkers are transforming acute kidney injury care from reactive treatment of established injury to proactive prevention and early intervention. By detecting kidney stress and damage hours before traditional markers, we can identify high-risk patients and deploy evidence-based care bundles and potentially prevent progression to severe acute kidney injury. While the challenges remain in standardization, cost, and development of treatment, the evidence base is strong and it is still growing. The future lies in integrated panels, AI-driven interpretation, and personalized medicine approaches that will make acute kidney injury a preventable and a manageable condition rather than an inevitable complication of patients who are admitted in ICU and patients who are suffering from critical illness. Thank you.